Hi, I'm Dr. Karen Phillips. I'm a cardiologist with a special interest in atrial fibrillation management, and I'm the director of the Brisbane AF Clinic. So today's mini course is about AF ablation, state of the art. There's a new ablation technique that's swept the world and is being used in most centres in Australia now for AF ablation, and it's called pulsed field ablation. So we're going to do a deep dive into this new type of ablation today, so you've got a good understanding of what your patients with atrial fibrillation are being offered, and how to talk with them about this new type of treatment and pros and cons. All right, so let's talk about biophysics behind ablation first. So ablation is just a term which means treating tissue with an energy source, and it's used across a lot of the fields of medicine, whether it's laser treatment, for behind the eyes. Radio frequency treatment is used for damaged nerves, endometrial ablation. Cryo freezing can be used for sunspots. We also use it for cardiac treatment. So the two types of cardiac ablation that we've had to date that have been used are now termed thermal ablation, and let's have a look at those. So basically, radio frequency was the first type of ablation back in the 1970s and 80s. We use radio frequency energy to heat up tissue and create a fairly predictable burn. So it's a heat injury to target heart rhythm abnormalities and circuits. The other type of cardiac ablation that's been used to date is also cryoablation. So that's a freezing injury. But as I said, they're both now lumped into what are called thermal ablation. So we're using thermal injury to achieve the ablation effect. Thermal injury basically causes irreversible cell injury from the overheating or freezing of the cell, which goes through a process then of inflammation, immune reaction, connective tissue replacement, which is effectively scarring. And to some extent, that's the desired result, that we're either getting rid of the specific troublesome tissue, or to some extent with AF ablation, we're looking for that scarring, but because it provides a type of electrical insulation to prevent arrhythmia events. Now, pulsed field ablation, so we're going to do a deep dive into, but the mechanism of pulsed field ablation is electroporation of cells. Electroporation leads to irreversible cell injury, and via a different process, though, and herein lies a big difference. So electroporation, pulsed field ablation leads to apoptosis, which is basically programmed cell death, and there's very little inflammation associated with this, but it still leads to connective tissue replacement. All right, what is electroporation? So basically, electric fields can damage cells, and they do so by targeting the lipid membrane of cells. So as we apply an electric field to cells or tissue, what happens is the lipid membrane starts to basically separate, and pores are formed. As the electric field strength is increased, those pores can become larger, but are still in a reversible state. And eventually, if you apply a very strong electric field, the cell will undergo irreversible pore formation. It won't be able to recover from, and then that goes on to cell death. So this is the actual mechanism of pulsed field ablation. Electric fields create electroporation injury to cells. Electroporation was first described in the 1960s, so it's certainly not a new therapy as such. It was noted at that stage that an electrical pulse would lead to increased cell permeability. They described these large pores forming in the cell membranes, and eventually, that would lead to irreversible cell injury and, as I said, programmed cell death. So if you recall, programmed cell death, or apoptosis is the other medical term, is a natural inbuilt defense that our body has, that cells that recognize that they're irreversibly damaged take themselves out. So they program their own demise for the good of the other tissue around. And as I said, that often involves very little inflammation because the rest of the immune system doesn't have to get involved to tell that's, to deal with that injured cell. The cell just organizes its own demise. A bit more detail about electroporation, as I said. Basically, the electric field is having an effect on the cell membrane. So, as you recall from way back in medical school, the lipid membrane is a dielectric layer, and basically, as you apply an electric field to it, it starts to become abnormal and pores open up within the usually completely intact membrane layer. But it also causes ion channels within the cell membrane to open when they usually wouldn't. So pore formation and damage to the lipid layer and opening of ion channels that would otherwise be closed. So the current applications of electroporation, as I said, electroporation is not a new concept or treatment. And it's actually been used in oncology for over 30 years, but they accessed mainly the reversible effects of electroporation that as you apply an electric field, you can make cells leaky, increase their permeability for chemotherapy agents, and then they go back to functioning normal after the electric field has been removed. Irreversible electroporation, so complete cell injury, irreversible cell injury and death, has been used commonly in wastewater management. Basically, any organism that's got a cell membrane, can be dealt with. So, water purification has used electroporation concepts for years, and food sciences, as well, dealing with bacteria. And of course, now cardiac ablation is another current and clinical application of electroporation. All right, some more differences with electroporation and this new type of cardiac ablation is the concept of tissue selectivity. So basically what we see with this graph here is as you apply an electric field to cells, they can experience injury. But different tissues experience injury at different thresholds or levels. And myocardium, cardiac cells, are particularly sensitive to electric field and electroporation. So they will basically undergo ablation at a lower dose compared with other tissues or cells around the heart muscle. So, for example, red blood cells, vascular cells, endothelium is a bit more resistant. So at the dose that we use to achieve an ablation for the heart muscle, these other tissues aren't irreversibly damaged. And then you can see the threshold for nerves is far higher. So this is one of the benefits of pulse field ablation, that basically we can achieve cardiac ablation with hopefully lesser or little risk to the other tissues around the heart. There is a caution though, because as we're going to have a look at, basically we are doing repetitive applications with this electric field. And obviously, if you repeat the applications many times, then you can get to the threshold of other tissues. All right. If you've heard about pulse field ablation, people are often talking about it's safer. So what does safer mean? And this is all relative, but one of the concepts with pulse field ablation is this safety margin for the other tissues around where we're doing the cardiac ablation. So when we look at these two graphs, basically they show that the safety margin for pulse field ablation is larger. What does that mean? So obviously, when we're applying thermal energy with cryo or radio frequency, this graph on the left, as we apply some energy, heat or cold treatment, we have to get to a certain point, strength of ablation, let's call it. Under that point, the ablation's not effective. The tissue's, not damaged and treated. And then obviously we have to be careful not to be too heavy-handed and to go too far. Otherwise, we won't only ablate cardiac tissue, we can damage other tissue around that area. So what we call this more narrow window of optimal dose and safety area where we're treating the cardiac tissue, but not leading to adverse events or complications with tissue around the heart. Pulsed field ablation, as you can see, has this wider window, and that's because of this cardiac tissue selectivity, that basically we can dial up the correct dose to achieve cardiac tissue ablation. And because the other tissues are much more resistant, we've got a wider, range before we're going to be delivering, doses that would affect surrounding tissue. So there's a larger tissue safety margin for pulse field ablation. Here's another slide showing that tissue selectivity. So, the gray area here is the cardiomyocytes, the cardiac muscle cells, which have been ablated, which was the desired effect. But nerves or blood vessels, in that area are unaffected. And one of the other concerns we have with AF ablation, doing treatment in the left atrium, the esophagus can be right nearby. And the esophagus tissue is not affected by the pulse field treatment at the doses recommended and generally used. All right, you're probably still wondering, what does pulsed field mean? You've explained everything about electroporation, but where did pulsed field come from? And how is this, new cardiac ablation actually performed? How is it different from the other types of ablation procedures? Well, pulsed field, I guess, is just a shortening of the name, because this therapy for cardiac ablation, the electric field is delivered in pulses. So it just shows here, similar to a sort of cardioversion or defibrillation, we apply, voltage and, energy electric field to the heart tissue. It's biphasic, so it's reversed, but it's delivered usually in packets of pulses. And if you're really interested in the biophysics of pulsed field ablation, electroporation, the strength of this electric field is basically in the region of 2,000 volts. If you remember that, mains power, when you plug in to a socket in the wall, that's 240 volts. So basically these are micro, sort of treatments in a very small area to the heart, but they're 2,000 volts of electric field that's being applied. Now, the pulses are repeated to achieve depth. So, as I said, there's a packet of pulses, and then we repeat those pulses because it's been shown that you need repetitive applications of this electric field to sort of push the depth. So this has all been studied to make sure that we achieve the correct depth of where we're trying to ablate the cardiac tissue. Now, this is the catheter that's commonly being used currently for pulsed field ablation. This is called the Farapulse catheter by one of the companies, basically the first one to be developed and to be used around the world for pulsed field ablation. And what you see is the catheter basically comes completely collapsed down. And then it opens up into different configurations, and these 3D configurations are important for how the electric field is delivered. So there's lots of little metal electrodes along this basket catheter, and where those little metal electrodes contact the tissue is basically where the electric field will be delivered in between these different electrodes just in that local area. So it comes completely collapsed down to be delivered up inside the heart. We open it up into different basket configurations to fit the pulmonary veins, as we'll see, and it can also be expanded out into this flower, flattened out into a flower shape to achieve the widest applications. Now, the bioengineering and physics of this pulse field ablation is pretty complicated, and basically it's different for every single catheter design. It's a complex formula that has to be worked out by engineers with bench testing and then subsequently, in real life. And every different catheter and conformation basically is a complex formula, not only of the pulses, but the width, the strength, the vectors, the catheter design. So every single catheter and company that brings pulse field treatment, to medical practice will and is having to go through this process of rigorous testing to work out how it actually works, how their catheter works, how it interacts with the tissue and treatment. But this is basically what the world's been using and what we're using currently, everyone's using currently around Australia. So this is the type of catheter that delivers the pulse field ablation currently. All right, let's go back to basics about the AF ablation procedure. And just to remind you, what we're doing with AF ablation is as a result of research from over 25 years ago now, some French doctors who studied the origin of atrial fibrillation and observed that atrial fibrillation was initiated by beats and rapid firing originating in the pulmonary veins, which attach onto the left atrium. All right. In the past, what we've been doing with ablation procedures for atrial fibrillation is either, as I said, radiofrequency or cryo ablation treatments. And this is what the radiofrequency treatment looked like. And this is what I was trained in and used. And obviously, we haven't given away with radiofrequency or cryo treatment. But as a first-line procedure for atrial fibrillation pulsed field ablation, as I'll show you, we've moved over to now. But radiofrequency ablation was essentially a hand-drawn ring of treatment around the pulmonary veins. So we aim to create a ring of treatment using basically a pencil keyhole, pencil application of radiofrequency energy. Creating complete rings of insulation to deal with the abnormal firing from the pulmonary veins, which is the source of atrial fibrillation. Now, as I said, previously we had just cryo treatment and radiofrequency. So as I said, radiofrequency is a hand-drawn ring of treatment around the pulmonary veins. And the cryo treatment was basically a balloon treatment. So blow up a balloon that delivered liquid nitrogen to create a circular freeze, to create a circular treatment around the pulmonary veins for ablation. So pulse field has many of the same aspects of the ablation procedure in common with cryo or radiofrequency ablation that we had been doing. Percutaneous access of the femoral vein. So from the groin, we come up the internal highway inside the veins into the heart, and we have to do a transeptal puncture, so crossover from the right to the left atrium in order to do the treatment around the pulmonary veins. Now, the pulse field ablation procedure looks like this. So this is a close-up of the left atrium and the pulmonary veins you can see here. And this is the Farapulse system catheter that I explained to you. So it comes completely collapsed down inside a sheath or long tube. And then we open it up into the basket shape. It's anchored with a guide wire, so a slippery sort of wire sits out the pulmonary vein to act as a sort of railroad, and then the basket can be advanced into contact with the pulmonary vein, and we can adjust the size of this basket to do the different size pulmonary veins or different treatments. So as I said, this is advanced into contact. Basically, the catheter and metal electrodes where they contact the pulmonary vein internal surface is where the electric field's delivered. So when we're in position, the machine is turned on and delivers the pulses of electric field. And that's approximately 2.5 seconds per application. And as I said, the applications are repeated for the appropriate effect. After we've done that application, obviously we don't get to see, what's happened inside the heart, but we can test to some extent the electrical properties of what we've achieved with ablation. But, this grey zone is a bit of a cartoon representation of the approximate area of ablated cardiac tissue. So, as I said, very strong electric field, but it's just delivered between those electrodes where it's contacting the tissue, and the ablation zone is only millimeters, in size that we've achieved. So very localized treatment. As I said, we can use this wider flower shape, which tends to reinforce, and basically it's preferred that we do a wider area of ablation around the left atrial pulmonary vein junction. So there is a workflow, as I said, with repeated applications and the basket and flower applications. But in essence, each vein requires around 20 seconds of ablation for full treatment. And then obviously that's repeated for each pulmonary vein. The average patient has 4 pulmonary veins. So you can see how quickly the treatment can actually be applied and achieved. So pulse field ablation, what are the pros? Well, procedure times are much faster than what we were seeing with the other types of ablation treatment. So generally now less than 60 minutes for the whole ablation procedure. There's very little inflammation after ablation. I said this is a key difference with the pulse field electroporation mechanism that is achieved through apoptosis and programmed cell death. So yes, in reality, we see very little inflammation of the tissues after ablation. So for patients, this means less chest discomfort. It was quite common with the other types of thermal ablation to get pericarditis, that the heart was inflamed after the treatment. There's less atrial stiffness. So occasionally we could see problems with cardiac failure patients, that the acute effect of the ablation, the stiffness of the tissue led to increased cardiac filling pressures and sometimes basically an exacerbation of their cardiac failure situation that required diuresis to reduce pressures and fluid overload at the time. Because there's very little inflammation, we don't see the same scarring problem that was recognized with the other types of ablation. So obviously, if you went inside the pulmonary veins with radiofrequency treatment, it would cause significant scarring, and the pulmonary veins would actually narrow down in caliber from circular scarring. We learnt a long time ago that you had to do these large rings of treatment outside the veins, not go in the veins, but we were relying on one ring of treatment for the effect. Because the pulse field doesn't cause this type of scarring, and there's no narrowing of the pulmonary veins noted in studies, basically we can now go back to doing treatments in and around the pulmonary veins. So we're doing multiple layers of treatment for the pulmonary veins, which should improve the efficacy of ablation. There's less AF that we see during the healing phase, so it can be quite common to get AF while everything's healing up for a start over the first couple of months. Doesn't mean ablation hasn't worked, but basically this can still be the case with pulse field, but we're seeing much less of it. And I think some of that's to do with reduced inflammation, that sometimes when the tissue's inflamed and irritable, it's more likely to have AF in the early stages. And as we talked about, yes, there seems little chance of some serious complications with pulse field, for example, esophageal injury with pulse field as compared to the other types of ablation. All right, what are the cons? The catheter I showed you is twice the size of the catheters that we use for radiofrequency treatment. So it's a very large sheath access, which means much larger hole in the femoral vein to go in. So we've got a higher risk of groin complications, but also complications from cardiac perforation, moving this larger equipment around. So there's a higher risk of pericardial tamponade as well, it seems. And I'll come back to safety because the complications from pulse field ablation are different from the thermal radiofrequency or cryo. So I don't like people saying this ablation is safer because basically there are certain aspects where you can, see increased risk of problems. And obviously the pros with this tissue selectivity where there's, reduced chance of collateral tissue injury. So complications from pulse field ablation are different. And we didn't see this with RF or cryo, but you can actually see significant hemolysis of red blood cells with high numbers of applications. So basically the electric field, that 3D basket is nicely zapping the cardiac tissue, but some red blood cells get caught up in the electric field and lead to hemolysis. and that can interact in patients with poor renal function and lead to acute renal failure, which has happened. So we have to be careful about different types of complications. The electric field also has a weird effect on the coronary arteries, blood vessels. As I said, it doesn't tend to damage them long term as far as we can tell, but it can lead to acute and quite severe coronary spasm if they're caught up in the electric field. So there are cases where life-threatening cardiac ischemia has resulted from coronary spasm and occlusion, temporary occlusion of the coronary arteries during ablation treatment. And the cons also include that for the time being, this catheter equipment and procedure is best suited for the first-time AF procedure, and it's not what I use for detailed arrhythmia mapping and repeat procedures at this point. We are going to see evolution of more companies, catheters, applications with the pulse field. So, but for the time being, the equipment we have, a procedure we have, is best suited for the first-time AF procedure. All right. You should be asking, well, what's the evidence that this is any better than what you were doing before? How does pulse field ablation compare with other ablation techniques in sort of head-to-head studies? And the most important one that we have so far is called the ADVENT randomized trial, and it was published in 2023. This study basically compared this Farapulse system catheter, as I showed you, randomized with radiofrequency or cryo balloon ablation, and they took patients with paroxysmal intermittent form atrial fibrillation and randomized them into the different ablation treatment strategies. Randomizing meaning they had a flip of the coin, so hopefully they all ended up sort of equally distributed. This is what the trial design looked like. So as I said, ADVENT trial was a pulsed field or thermal ablation for paroxysmal atrial fibrillation. So they took 607 patients with paroxysmal intermittent atrial fibrillation pattern. And half of them had the pulse field ablation treatment and the other half had thermal ablation. So, a quarter had cryo, a quarter had RF, and half had the pulse field. So what were the results? So I gave you a sneak peek of everything then. So primary efficacy relates to, well, how well did it treat atrial fibrillation? So we're looking at reduction or freedom, from atrial fibrillation after ablation treatment. And 73% of the group who had pulse field ablation were free of AF, 71% of the thermal group. And the conclusion there is they're very similar, no real difference. Although obviously the argument around pulse field is, well, you guys have been supposedly perfecting these other types of ablation for 20-something years now. We've come in with our first attempt at this new treatment and we're already achieving the same, maybe indication it might be better. And certainly I think that's been the subsequent experience, as I said, especially, we do seem to be able to offer more efficacious ablation with the pulse field advantages. So I suspect that if this trial was repeated now, with the further advances in, catheter and ablation procedure with the pulse field, that number would actually be higher. This is the evidence we have to date. So essentially they offer similar outcomes for AF treatment. And this was the primary safety outcome. So are the two procedures, just as safe as each other? And there was around 2% safety issues or complications with the pulse field and 1.5%. So deemed to not be any different. I will point out there was one patient death in this study, and it was in the pulse field ablation treatment. And a patient had cardiac perforation and died of pericardial tamponade. Now, we'll talk a little bit more about this, but as I said, I keep coming back to safety. If people say that pulse field ablation is safer than the other type of ablation, well, there's lots to talk about with safety. As I said, there's no significant difference really between these two procedures, techniques, safety in the end. As I said, they have different types of, of safety issues, but we'll deep dive a little bit more into, this safety on the next slide. So safety of AF ablation, there are two considerations. One is that there are safety issues that are related to ablation energy, and that's what we were covering about tissue selectivity, increased safety margin with pulse field ablation. So we can perform safer cardiac ablation with less chance that we're going to damage, other tissues which we didn't intend to around the heart. The other issue with AF ablation procedures is some safety issues and complications, plain and simple, related to catheter access, instrumentation of vascular and cardiac structures. And no matter whether you're doing RF, cryo, or pulse field, we have to go into the groins, do a transeptal puncture, get across to the left atrium, move equipment around inside the blood vessels and hearts as safely as possible. So these other types of complications can include risk of vascular injury and bleeding, risk of cardiac perforation, and risk of blood clotting on equipment in the left atrium, leading to potentially ischemic stroke. There are differences between the procedures, and I wouldn't say at the moment that pulse field ablation is definitely safer. All right, what's been my experience with pulse field ablation at the Brisbane AF clinic? So we've been using the new procedure and equipment for around 12 months now. I would say improved results for first-time ablation. So usually the efficacy is pretty good. We were talking 70, 80% for a lot of patients. But a percentage of patients, previously it was probably around 10% of my patients, might have to have a repeat ablation early on if they didn't get a good result, because gaps could open up in that radio frequency ring, and we might have to touch things up to get a better result. So I would say probably more than 90% efficacy of the first time procedure now with pulse field ablation. Excellent patient recovery experience. As I said, this reduction in inflammation, less pericarditis. Most patients leave hospital the next day and have a very easy time of their recovery. As I said, there's very little AF we've seen in the healing phase, and that means that the results are almost instant. So patients know that they've had a good result from their ablation, and we don't have to wait a couple of months and explain away, some of the arrhythmias that can happen because of inflammation and healing before we can see the final outcome. Because of how fast the procedures are now and efficient, basically we can do double to triple the procedure numbers that we were doing before. So that's beneficial because there's really, no wait list at my clinic any longer for an ablation procedure. And in my hands, the safety has been excellent. So we've really had no major issues. And obviously you have to account for some of the changes and differences with bigger sheaths and the differences in catheters and maneuvering. But safety has been excellent from my perspective. All right, so that's an overview to pulse field ablation. And I'm just going to stretch you out a little further. As I said, state-of-the-art AF ablation. So where are we at in 2025? Is there anything else I can tell you that's important in the AF ablation arena? And there is, because every couple of years, the international guidelines on AF management seem to be being updated because we have such a flood of new evidence and treatments coming online. So these updated guidelines from last year now, basically AF ablation is recommended as a first-line treatment for patients with paroxysmal atrial fibrillation. So this is pulled straight from the guidelines, so I'll read it out for you. Catheter ablation is recommended as a first-line option within a shared decision-making rhythm control strategy in patients with paroxysmal AF to reduce symptoms, recurrence, and progression of AF. Class 1 recommendation. So part of the story behind this is we know how effective AF ablation is. and we should probably be offering it to patients sooner in the course of their condition. And one of the important aspects of early treatment of AF is stopping AF from getting worse over time, and particularly from paroxysmal or intermittent pattern of atrial fibrillation progressing to persistent AF. So persistent atrial fibrillation is where atrial fibrillation becomes continuous or for long periods of time, and or you need to go to hospital to have treatments like cardioversion to get the AF episodes stopped. Research shows us that persistent AF is a more advanced sort of form of the condition, but it's associated with poorer prognosis. So persistent atrial fibrillation patients have a higher risk of heart failure and cardiac hospitalization. They have a higher risk of stroke. We all know the moniker AF begets AF. So AF does tend to get worse over time, especially if it's not treated early or treated appropriately. And studies suggest that in patients over the age of 60 years, around 15% of people with paroxysmal AF will progress to persistent AF within 1 year. And that's probably even worse the older our patients are. So there are higher rates of progression with older age, or if patients have other types of cardiac conditions or hypertension. Atrial fibrillation ablation, if it can be applied sooner and to patients with paroxysmal atrial fibrillation, we may be able to stop them from getting to the point of persistent AF associated with poorer health outcomes. All right, more breaking news, but this is not the latest news because this was breaking news back in 2021. And as I said, again, this is the sort of basis to why atrial fibrillation ablation treatment is now being recommended sooner and, and indeed, first line in patients. And that's because we discovered from this important clinical trial back then that catheter ablation definitely delays this progression of atrial fibrillation. So this was a randomized trial. And basically, they took older patients, so over the age of 60 years with paroxysmal atrial fibrillation, and they randomized them to either have radiofrequency ablation treatment or to take antiarrhythmic drugs. And during follow-up, they noticed that very few patients with ablation treatment went on to develop persistent atrial fibrillation. So 2% and 17% of patients, despite the fact they were taking antiarrhythmic drug treatment, their AF got worse over time and they developed persistent atrial fibrillation. All right. The other concept that's important too is that the earlier ablation is performed, the better the result. And again, this is part of the explanation behind the move towards first line. So if you have AF, the intermittent pattern, think about ablation early. Let's not delay people by asking them to take antiarrhythmic drugs, which may or may not work, may or may not prevent their progression to AF. So the earlier patients can access ablation, the better their control of AF and subsequent health outcomes might be. So why early ablation? Well, there's a bit of talk around this diagnosis to ablation time. So even patients who are probably planning on having ablation at some stage, the less AF, that you let them have, and the earlier you get them to ablation, you can improve their outcomes. So the time between AF diagnosis and their first ablation, or this so-called diagnosis to ablation time, is an emerging marker of clinical response. So basically, if the time between your diagnosis and your ablation was 1 year or less, they found that you had a significantly lower risk of AF recurrence and better rhythm and health outcomes subsequently. All right, well, I'm going to wrap it up there. So here are the take-home messages from the AF ablation state-of-the-art course today. And some of these I haven't gone into in depth today, but it's to remind you that AF is a complex condition and education, shared decision-making is required along with dynamic review to get patients, the best results and health outcomes over time. As I said, it's moving goalposts, especially patients who have paroxysmal AF. If you're not looking, next thing they have persistent AF, and it changes their risk of, of complications. So We need to be taking patients along for the journey, educating them properly about their condition, what things to look out for, and frequent review to make appropriate, treatment decisions or changes with time. As you can tell, and I'm probably biased, but evidence is leaning towards rhythm control preferred for cardiac health outcomes. So if we can stop AF from happening as best possible, keep patients even in a paroxysmal rather than a persistent pattern of AF, they're going to have better health outcomes. And generally that'll be with treatment. We still use antiarrhythmic drugs, but as you can tell, ablation for atrial fibrillation is becoming much more mainstream and commonly used to achieve some of these better health outcomes. As I said, AF ablation can be recommended first line instead of rhythm medications to patients with paroxysmal AF, so intermittent, AF. It's not one episode of AF, so this is usually patients who have at least a regular pattern of episodes that we want to talk to and direct them earlier to consider ablation treatment. And of course, many patients still rely on their trusted family doctor to advise them on the best course of action. So I can take them through the nitty-gritty, but GPs and physicians really still need to be across all of these concepts so they can give best advice, to their patients that they know best, as to what's the right course of action. And all right, final slide, really take-home messages. I said a good understanding of what AF ablation involves and the pros and cons is essential to GPs and physicians. Pulse field cardiac ablation is a new technology, but it's now being widely used for AF ablation in Australia and around the world. So this presentation has given you an overview of the biophysics behind pulse field ablation, how the procedure is performed, the potential benefits that it offers to patients, and the differences from other types of cardiac ablation. All right, I'm going to finish up there. This is the latest in a series of mini courses on atrial fibrillation management issues. So if you want to check your knowledge, go back and check out some of the other mini courses on atrial fibrillation management. I'm Dr. Karen Phillips, Director of the Brisbane AF Clinic. Thanks for your time.